Hi, everyone. We're about to get started with abstract session number 4. You could take your seats, please, and if our presenters could be nearby, waiting to be called. Good morning. Nice to see so many friendly faces in the room. My name is Ifeoma Udoh. I'm with the Pangea Global AIDS Foundation, and I will be moderating this session today with my esteemed colleague, Dr. Sheri Weiser. And we are presenting the abstract-driven session on social context and community engagement. And our speakers are listed on our front slide there: Dr. Cynthia Gomez, Nicholas Alvarado, Marguerita Lightfoot, Danielle Gordon, Amina, Yusuf, and Susan Kaglis. We're really pleased to have such a breadth of experience as part of this discussion and look forward to engendering a lively discussion with everyone today. So when we talk about what we mean around the social context and community engagement, obviously we've heard a lot of information that sets the stage for what these critical issues are in the communities that we work in. At a policy level, we've heard a lot today, and obviously we've been hearing a lot about the National AIDS Strategy. Prevention definitions are starting to shift with the IPREX and the PrEP findings, moving towards prevention as making prevention be more about onwards prevention versus new infections, and how do we kind of start to think about what that means. There's obviously a re-energized focus on biomedical interventions and healthcare reform, which we heard a lot this morning from the Project Inform presentation, and the accessibility issues around that, so changes to Ryan White, ADAP, et cetera. So in terms of the role of engaging community and what we mean by that, and with respect to this issue of addressing health disparities, the communities that we work with have the breadth and the depth that we need to access populations that are most at risk, but how do we begin to create this cyclical awareness around where it is that they can intervene? So there's these contextual barriers of community change, institutional change, and what are the research issues that come about in terms of identifying the gaps of information that we need to explore those opportunities for intervention, and what kind of methods that are available to us in order to address those gaps and decrease health disparities and increase health equity.
Actually, we were going to save those critical questions for the end, so we'll pull them back up. So just to recap some of what we've been talking about here, we've heard at length about the barriers to the Cascade and the fact that the vast majority of HIV-infected people are not engaged in care and achieving viral suppression. And we've talked a lot about some of the barriers and why are these barriers so complicated. Well, the individuals are affected not only by individual level factors, but also by important issues in their interpersonal, social, institutional, and structural environment. So we've talked about important individual level barriers like mental illness and substance use, language barriers, food insecurity, and interpersonal violence, among others. We've talked about community and institutional barriers that are very important, such as HIV stigma, under-resourced clinics and community-based organizations, really difficult to access testing and treatment services, and a lot of the focus at this conference has been on what we've been terming upstream barriers, so structural barriers like the socioeconomic and geographic disparities, gender disparities, and racial disparities, among others. And we've started to talk about some important strategies to address these barriers at the various levels. So we've talked about things like financial incentives and starting to address housing and food insecurity, co-treating substance abuse and mental illness, important strategies for going out and testing people that are difficult to reach, addressing social stigma at the community level, using a multidisciplinary approach with strong case management to simultaneously address the health, socioeconomic, and social needs of our patients, and finally, targeting discrimination and all of the levels of discrimination at a broader level. And part of how we do this is by healthcare reform, which we've heard a lot about this morning. So this panel will continue these discussions by focusing some on the client perspective, on the key barriers to care. We'll hear some of the barriers from minority populations and from difficult to engage populations. And the panelists will start to address how to move across these barriers at these different levels in coming up with solutions. The second point of the panel will be really to think about this, to step back and think about this from an organizational perspective. So how can we learn from the communities that we are trying to serve and better link to the target populations? How can service providers, community-based organizations, and other people working with these populations better link with one another? And importantly, how can this work be sustained over time? And I'll just leave you with some guiding questions that really have been some of the questions that have guided this whole conference. So we've been, one thing that we've been focusing on are what are still the gaps in our understanding of the barriers to engagement in HIV care. We've heard a lot about that, and we'll hear a bit more. The next level that we're thinking about is how could some of the strategies that we're learning at this conference be sustained and applied elsewhere. And I think that the crux of this panel will focus on the middle question, which is namely how can community and academic partnerships really propel this work forward? Why are these partnerships so advantageous, and how can these a partnership model really be able to distinctly address the multiple barriers of the most marginalized populations? So with that, I would like to call up our first speaker, and what we're going to do, because we have so many speakers here and it will be difficult for you all to see, is we're going to call up speakers one at a time. We'll have you come back in the audience so you could view the rest of the presentations, and at the end we'll come up and call you up for the panel discussion. So it is my pleasure to introduce the first speaker, Cynthia Gomez, or the first speakers, Cynthia Gomez and Nicholas Alvarado from San Francisco State University Health Equity Institute. And the title of their talk is Linking HIV-Positive People to Care Through Developing a Diverse Network of CBOs.
Good morning. Before I start, just a quick announcement. I've left some flyers out on the table. We have a Cuban scholar visiting in a couple of weeks to talk about intersection of gender, race, and HIV. And it'll be interesting to compare a society where access is completely available and how they're still struggling with those. So just wanted to make that announcement. So we want to talk about a systemic change that we have been working towards, and I want to acknowledge the rest of the team, and you'll hear from some of them in a moment, in an effort to engage and link individuals into care. And the background really was to recognizing that many community-based organizations, at least in the Bay Area, are most times competing with each other for very scarce resources to do their work. And this really discourages collaboration across agencies. Nobody wants to give away their secrets or feel that maybe, again, they're going to take resources away from each other. So we developed a model to bring organizations together and created a multi-agency model that is 11 community-based organizations and called the Bay Area Network for Positive Health, or BAMF, as we're known in the community as. And it's really a wide range of agencies, which I'll say a little bit more about in a second. And the specific goal of BAMF is really to build the infrastructure for interagency collaboration, reduce the number of HIV-positive persons that are out of care, and ultimately decreasing HIV transmission rates in the Bay Area. So as you can see, I'm trying to walk the talk, which is really to move into these structural challenges within the Bay Area that we have seen for many, many, many years, despite our progressive area. So how did we do this? We as a local team, meaning the academic based team, identified and brought together agencies that had complementary strengths and abilities that would really give us greater capacity through this multidimensional network to accomplish our goals. And the network ended up then coming together, and together we wrote a proposal. Together we designed our model, competed for these funds, and succeeded in being funded to implement this model in the Bay Area. So one of the first things we did is to really look at how do we do this most effectively. And so in San Francisco, we had the benefit of the great progress that had been done in documenting community viral loads. And so what you see, which I know is hard to see, so I apologize, but on this side, and this goes when we were doing this application, so it's a little outdated, but this is a map of the concentration of where people living with HIV or AIDS live in San Francisco, because this is where we had the data. We don't have it for Alameda County, or we didn't have it available then. So you can see the darker areas. This is sort of where folks with HIV are living. However, when we look at community viral load, meaning where are folks who are clearly not receiving optimal HIV care, the map shifts. So the Castro, for example, where we have the largest concentration of people living with HIV, actually drops out of the map. And again, so we immediately see just through this map the change, and we end up with the 3 target locations that we have, which is south of Market, Tenderloin, Bayview, and Visitation Valley in terms of the San Francisco outline. And trying to think similarly about Alameda, although again, structurally, Alameda does not have the same luxury that San Francisco does around data access and manipulation, if you will, to provide this very important information. But we use this information to help us think about targeting our efforts for the agencies involved. And then our service design was a little different, meaning that we started in identifying agencies that we were working with non-HIV agencies, because we're looking for people who know they are positive and are not accessing care. Why would we go to the HIV agencies? I would certainly hope that those agencies are trying to link people into care if they learn that they're positive and not in care. So part of it was trying to bring in agencies that would most likely be interacting with the populations that we're trying to find. We also wanted to have, obviously, agencies with good HIV skills, and so we did bring in some HIV CBOs, and obviously our care providers are a critical important link as well. But we had others, and I'll say more about. So here is our entire network to give you a range. So again, we served as the lead intermediary from the national funding agency, and then we have a real mixture of organizations, as you see here, that were part of the network. And it included both San Francisco Health Department and Alameda Health Department, critical players, and their role is really related to our strategy. So we have sort of 3 intense strategies. One is how to monitor through the health departments what we're doing and how we're having an impact. And some of that is really learning to see, can we use surveillance as a verification? We're working really closely with both health departments to see, is this achievable? I mean, it's something that at the national level at CDC has been talked about. We don't use surveillance data, and we need to use surveillance data for really to inform what we're doing. And again, also to find out where are people dropping out of, where are the testing sites where linkage is lowest, and sort of the overall community viral loads. System improvements, really doing a lot of provider training, capacity building, introducing tools and technologies to the community-based organizations, and us learning a lot from the community-based organizations as an academic team about the different cultures within the different agencies and how that drives efficiencies and dysfunction. And then, of course, at the individual level, actually locating people and linking them into care. We have a particular focus now on reentry, which is assuring linkage for individuals leaving jails and prisons. And finally, just what have been our challenges? Well, there have been many challenges. Certainly at the network level, I think all of the agencies involved were a little surprised by the amount of technical assistance that was needed and assumptions about what we all thought we knew how to do. So many agencies who felt, well, we know how to do street outreach. We were actually talking about something very different, not the cold outreach of approaching somebody on the street, which is really what's required for us to be successful. So it really took all of us being humble and have a lot of willingness to recognize what we needed training in, and that is sometimes a challenge, as you well know. And functioning as a system. You know, so one of the things we're talking about here is all the different agencies, and we don't function as a system. Even I think our panel yesterday, Maurice was saying, well, how come they're not functioning as a system, right? Why aren't we all talking together? And that's a huge barrier. We don't function as a system. And then the other challenges, of course, were community politics, sort of what's going on, and that whole still tension about who's doing what, identifying and tracking the confidentiality issues, which you can read a lot more on our abstract about, and then provider training. Providers don't think they need training most of the time. And yet we know that that's where a huge barrier is for the people that we're learning from, and you'll hear more about those barriers. Finally, what do we think the impacts are of this, of BAMF? We're increasing agencies serving HIV-positive people. We had agencies that had never, ever in their agency discussed HIV, who are now leaders in reaching very, very disenfranchised populations around HIV. It's something very, very wonderful for us to see. And that has brought many things, including the, locating hidden populations, like a whole sort of cluster of Burmese people living with HIV who have never accessed care, et cetera. So very important impacts. It increases the collaboration. The idea that this is a network that goes across the Bay Bridge was sort of a new notion in the Bay Area because of siloed funding. So this ability to have a private funder that would allow us to fund both sides of the bridge was really exciting. I think most of the agencies feel excited about that. And again, increasing agency capacity. I mean, we see it in one agency where they actually changed how they communicated between different departments because of our program. And they suddenly realized where their gaps were at the micro level. And then, of course, at the macro level in terms of how agencies can actually depend on each other and rather than compete with each other, so that they can share knowledge and share services and share resources with their clients who they're serving, which is really, their main purpose. So it's been an exciting program. We're still in the midst of it, so we're just telling you sort of where we are at right now. And please feel free to look at our website, find more information, and to see the various posters that relate to BAMF. Thank you.
Thank you very much, Cynthia. So the next presentation is a peer navigation assessment for HIV-infected African-American men in Oakland, outcomes of 2 focus groups. And I would like to welcome Nicholas Alvarado, and I think Maurice Graham will be joining the conversation as well later.
Yes, he will. Good morning, everybody. So what we're talking about here is, let me get it started. Oops. I'm having technical difficulties here. Okay, keep on going. Why is it not advancing? Need some help here?
Is there someone that could help?
Oh. Apologies. Okay, now. So this is based on outcomes of 2 focus groups, and these are for African American men in Oakland with a focus on men who have sex with men. And our objectives for these focus groups were to learn what the barriers and facilitators are in seeking and maintaining care among HIV-positive African-American men with a focus on men who have sex with men. And the other objective was just to get feedback on whether a peer navigator program would be effective in linking these men to care in the East Bay. And also I want to just say, what we're going to be presenting here is not specifically I mean, it's for Oakland and the East Bay, but it really does systemically affect everybody, and we're focusing on here, but it's for everywhere. And this first bullet kind of indicates the problem in the East Bay of 11% in the TGA in Alameda County and Contra Costa County make up 42% of HIV infections and 43% of the AIDS diagnoses. And then we know this one already. This has been talked about a little bit in the past already, as has this yesterday and today, this morning. And this last one, distrust and stigma, are definitely barriers in HIV disclosure among African American men. And this does, I think, impact their access to care, which we'll talk about a little bit later. So the 3 questions that we asked in both focus groups were, what are the reasons these men are not accessing care, or adequate care if they are in care, and what would help them access care and keep them involved in their care? And then last one is, what would make a peer navigator program successful for these men in Oakland? And so we had, before I go to that theme, I want to also say that we had 2 focus groups, and one of them were basically on community leaders comprised of providers, faith-based organization leaders, and some clinicians as well. So, and with that we found 3 main themes, and the first one was stigma around sex and HIV from family, friends, work, and church. And under this was some sub-themes or ideas of the lack of information around HIV from transmission to care and everything in between, and how it's just missing in a lot of people's areas of concern and what is driving some of the stigma. Also, there's the internal and external homophobia, which I don't really need to say much of, and then lack of trust and confidentiality around support and care and disclosure. And then fear and denial, which was a really big one. It was fear around death, rejection, medication, and the denial of the disease progression, and just fear of being rejected as well. And then the third theme we had was the expectation of inadequate care, which was very prominent. And that was driven by the inaccessibility of HIV care services, basically, oftentimes. And people go to a place that they're supposed to get service, and it's not there, it's been broken down, shut down, or it's not adequate. Also, historical distrust, which was really big, based on Tuskegee, just on hospital discrimination of history, and just the conspiracy beliefs as well. The other one was providers' assumptions and attitudes, judgments, and the voyeuristic ways of sometimes treating their patients. And they were just really, a lot of the guys were just talking about how that is just really a painful place to be when they're trying to take care of themselves and do the best they can in their own treatment. And then also perceptions of the pharmaceuticals and their companies of them making a profit, more profiting over patient care. And that was a big issue with them. And then the last thing that we had was the HIV education and resources, which I'm going to let Maurice finish up on. Right.
Which button is it?
The right one.
Okay. So now we're at the stage where we can actually look at what peer navigation might be able to address. And the 2 groups, again, one was a provider group, including faith-based, and the other one was a group of community leaders or advocates, So what we discovered through peer navigation is that training was one of the major issues that came out of the conversations with both groups. And that is training not only the advocates, but training the community itself, looking at how the doctors are working with their clients and what kind of information is being transmitted between the 2, the client and the doctor. Resources. We talked about the resources not being available, but as a navigator, a peer navigation project could actually put information in the community's hands by training the navigator themselves on what resources are available, and then also looking at what gaps exist in the community and how we can address those gaps by offering communication between the provider and the clients themselves. Outreach. The outreach piece that was discussed talked about how we could advance beyond, especially dealing with the stigma, beyond the men who have sex with men community into the larger community, because men who have sex are embedded in the community in the first place. But the solution isn't just about men, it's about the entire community itself. And so they believe that what was necessary was to make sure that we were including the family, friends, and work relationships in the outreach process so that the stigma could be reduced. And education, educating both the clients and the navigator themselves, because the navigator in this resource-poor environment could provide some of the relief that's necessary in communicating the changes that are taking place. There are so many changes taking place that it would take a lot of education and training to keep a navigator abreast of what would be necessary for the people that they would be working with, and in this case, it would be men working with men. Support and empowerment. One of the things that was discussed was how there's a women's program already in existence with navigators working through that program, and their relationships are more emotional than what the relationships might be with men. And, you know, for me that's debatable, but what they said was that what we actually need was a way to empower each other. And the discussion was around men modeling each other. You know, so when a man is taking care of himself and is in a position where his viral load, for instance, is undetectable, that is an example to other men and the relationships that they have with those men to bring them to a place where they can actually see that possibility for themselves. Build trust, respect, and healthy relationships. Well, this is about meeting men where they are. And that's what came over time and time again in the conversations, how men actually need to address men at their own level. And a navigator could provide that kind of relationship, especially those people who have been around for a while and understand how to negotiate and adapt to the changing environment that we're experiencing. Navigators would look at what would be the best circumstance and situation as far as service is concerned for the individual. So it is a model that is what we believe at this point in time would be necessary. Participants appreciated the focus group involvement, and some were skeptical. Some said that, you know what, this is a good model, but what we believe is that there's still so much fear around disclosure and developing this kind of relationship that it would be difficult for some people to make that gap. Other people talked about how that might be just the place where we plant the seed and they then grow into a place where they can begin to develop those kinds of relationships, especially as they see that kind of relationship working with others. Genuine support, respect, and meeting the client where he is.
We're going to have to finish up.
Okay. And further exploration is needed. That needed exploration is about now developing a model where we can actually look at what it takes to educate a navigator and what we could do to further this concept. Thanks.
Thank you very much. It's my pleasure to introduce the next set of speakers, Marguerita Lightfoot from UCSF Center for AIDS Prevention Studies and Carla Dillard-Smith from CalPEP. And the title of their talk is A Community Academic Collaborative to Reduce HIV/AIDS Health Disparities in the African American Community in Alameda County.
Thank you. Good morning, everyone. Let's try that again. It's a call. See, you thought you were going to get out of it. No such luck. You're going to have to listen to us talk anyway. All right, so Carla and I are going to be telling you about an experience that we've been having around bringing community academic researchers and building community researchers and coming together with some ideas and being able to develop a research agenda in Alameda County, which requires some out-of-the-box thinking and approaches. And so we're going to start off a little bit out of the box today, and we have no slides. We're just going to talk to you. And so first and if you want slides, we do have a poster number 29 back there that kind of summarizes this program. But what we thought we would do is just tell you a little bit about what we're doing and then what's worked well and where our challenges have been to inform how do we get academics and community folks together to be able to build some new research questions that really address the HIV epidemic, particularly in African American communities and specifically in Alameda County. So we are now embarked on a journey together that started about almost 2 years ago. We have funding from the National Institute of Minority Health and Health Disparities to build infrastructure to be able to do community-based participatory research. So of course we are coming at this with the assumption that it's better for us to work together as opposed to me as an academic coming up with some really brilliant and informed ideas and deciding what kind of research needed to happen, and then trying to bring in and drag in my collaborators by writing me a letter of support or helping me get access to clients. Some of that, there's a lot of valuable research like that, but one of the things that we're lacking is progress. And we've made minimal progress so far. And partly that might be explained by maybe we're not asking the right questions and maybe we're not addressing things the right way. And that maybe we need to actually begin to have more partnerships where we're talking to the folks who are on the ground doing the work and seeing, well, what are you seeing? What are the questions that we should be asking? And how can I, as a researcher, bring my expertise, and you, as a community person, bring your expertise to the table to begin to think about, well, what's the best way to go about this? So this is a collaboration between UCSF, the Center for AIDS Prevention Studies, AIDS Project of the East Bay, CalPEP, and World, primarily. But the idea is to bring in a number of partners from across the Bay Area, Cal State East Bay, San Francisco State, all the academics, and many of the community folks in Alameda County to begin to address this question together.
So, what worked well? ARC brought community organizations, individuals, and researchers together. There's a planning group that meets monthly to frame activities. The planning group ideas are brought to a broader community meeting, and the group decides jointly how to proceed. Early on, the group decided that there were opportunities to work together, so we established a dating process to pair up. Realistically, this resulted in about 4 pairings. There were more conversations, but they didn't really move forward. But the pairings moved forward in some way. I'll talk about that a little later. Well, I'll talk about it now. ARC conducted an RFA process in which partners or people from the broader community could apply for 2 $20,000 each. We were going to allow 2 $20,000 pilot grants. 3 groups applied for the pilot grant. 2 were awarded. There was a follow-up meeting and a learning opportunity for recipients, the people who didn't get it, and the reviewers to share experiences using an abbreviated NIH process.
So one of the things that we were really hoping to do was to ignite some innovative new research. And the way that we did that was by actually funding these community partnerships. Community academic partnerships were half of the money, were the community partnership we needed to make sure that some of the funding went both to the community as well as the academic researcher. We have, and at some point hopefully you'll be hearing the results of those studies. One of the studies is a collaboration between San Francisco State and HEPAC, and they are looking at what are the facilitators and barriers to African American IDUs completing methadone treatment. And really that being the first step in really being able to prevent a number of the other health issues that happen with this population. The other pilot study that we was awarded to UCSF and AIDS Project of the East Bay. And they're looking at HIV-positive African American men who have sex with men who are dually diagnosed with the substance abuse issue as well as depression, and beginning to build an intervention that's intended to address the risk behaviors of that population.
So what's challenging? Maintaining participation of university partners. University partners participated in a retreat to familiarize community and university partners with each other. Again, several partnerships resulted, and 3 were able to move forward, 2 to apply for the pilots, and 1 applied for Ford Foundation funding. University partners indicated an interest in knowing what research was taking place in Alameda County, and a lot of the decisions around partnering, of course, was based on the work that they are currently involved in. There was also an issue of time. The times that we had the meetings and people needing to commute or get back and forth and pick up children and that kind of thing. So it was challenging. The other challenge is maintaining the participation of community members that we've invited into the process. Community partners and community members were interested in learning more about research. So basically we had to back up and talk about research, give definitions, and actually train people to talk about research questions and develop research aims. This, of course, was not an interest for university partners. That's what they do every day. Community partners are impacted by funding issues and appear interested in activities related to funding and grant writing. Also, capacity development in relation to understanding research, in particular community-based participatory research. I'm repeating myself. Developing questions and aims was not needed by university partners. We received feedback that it would help to identify separate areas of interest to researchers and formulate an agenda to reflect those interests when capacity building activities don't apply. When we ask, that's it for now. That's what was challenging.
Okay. So we spent a lot of time getting academics and community folks together at the same table. And we had a lot of different activities to get these 2 groups to talk to each other, because really what we were talking about was building relationships. And so as Carla said, building relationships, so that's why we kind of talked about it as they talked about it as dating. Like, it's really who should you be talking to, what should you be asking the other person, what makes sense in terms of who's good to work with, what do you care about, as well as what are your own interests, and so helping people make those connections. And so we spent a lot of time at the beginning doing that, and then from there, they began to identify a lot of things that they wanted to learn about, both the academics and the community folks. And they were different things, which we knew already. And so now we're moving towards being able to do more capacity building for both the academics and for the community folks separately, now that we have folks who are interested and who are engaged in the process.
Okay, so how has it changed over time? ARC has moved from very broad discussion and brainstorming of issues surrounding the need for research in Alameda County to specific activities. Feedback from participants suggests that the pilot grant, the RFA process, was very educational for community participants. The process was debriefed, and it really clarified what researchers go through with the NIH review process. Moving forward, ARC is developing an electronic archive for community research collaborations, documenting our experience in providing resources. ARC is developing a research agenda. Marguerita already spoke to that. And it includes ideas for intervention and opportunities for ARC grant submissions. Finally, ARC is planning a research meeting to inform affected community members and researchers about what research is going on in Alameda County.
And if we weren't clear, ARC stands for the Alameda AIDS Research Coalition. Thank you.
I would like to introduce our next speakers, Ms. Danielle Gordon from the Health Equity Institute of San Francisco State University, and Ms. Debra Allen, also as well from the Health Equity Institute. The title of their presentation will be Engaging the Invisible, Locating and Linking the Long-Term Out-of-Care People Living with HIV in the Bay Area.
Good afternoon, everyone.
Good afternoon.
Thank you. Okay, so okay. Oops. I think I'm doing. Okay. Background. There are 650 people living with HIV or not receiving HIV care in the United States. As we know, HIV treatment is critical to ending the pandemic. It is estimated that 8,000 individuals in San Francisco and Alameda County with known HIV not receiving adequate care. Little is known about the contextual realities that keep people living with HIV out of care in the resource-rich setting of the San Francisco Bay Area. BANF is a collaboration of 12 CBOs, HIV clinics, and County Department of Public Health. Clients are located through a variety of outreach strategies. Data are collected on barriers to care, experience of stigma, quality of life, needs, and demographics. Eligible individuals are offered assistance to access HIV care and other support services. Client characteristics are known positive average of 10 years, 34% reported no high school diploma or equivalent, 63% over 40 years of age, 66% reported living in someone else's home, a treatment center, SRO, shelter, or outdoors. Barriers. 44% reported drug use, 40% reported having transportation issues, 39% reported having homeless issues, and 39% reported competing priorities. Conclusions. Barriers to care have been persistent and difficult to remediate. Other priorities needs must be met before linking to HIV medical care. And extra time and additional resources are imperative to reach and link those individuals critical to the containment of the pandemic. Thank you.
Great, thank you very much. Our next speakers, Ms. Amina Yusuf from CalPEP and Ms. Christina Grijalva from La Clínica de la Raza will be presenting about community-based participatory research approaches to understanding and addressing late HIV diagnosis in Oakland, a collaborative case study.
Hi, good afternoon. I am Amina Yusuf from CalPEP in Oakland, California, and this is Christina Grijalva from La Clinica de la Raza, also in Oakland, California. Today we are presenting on behalf of all of the co-authors who are listed on this slide, and also on our poster, which is number 18. So the background, we are talking about late diagnosis. So briefly, late diagnosis is a simultaneous HIV and AIDS diagnosis or progression to AIDS within 1 year of the original HIV diagnosis. So late diagnosis of HIV is increasing in Alameda County. It's up to 57% in 2010 from 39 in 1998. And of those who are late diagnosed, 50% are African American, and Latinos are actually 1.2 times more likely to be late diagnosed in Oakland. 68% of Latinos in Oakland living with AIDS, 68% of Latinos living with HIV/AIDS in Oakland are late diagnosed. So using a CBPR framework, Pangea Global AIDS Foundation, CalPEP, La Clinica de la Raza, Alameda County Public Health Department, and UC Berkeley have partnered to address this issue. Our study objectives are listed here, but this presentation is going to focus primarily on the first bullet, which is to elucidate the individual and structural barriers to earlier detection of HIV. And additionally, the fourth bullet is to pilot test promising community-driven responses in Oakland.
So our methods that we're using. So we're using peer recruitment methods, and they're adapted from RDS strategies. And we use these to identify the focus group participants. So eligibility, participants who had not received HIV testing for HIV prevention and education services within the past year. We conducted 13 focus groups with African American and Latino participants. And our target risk groups were, or are, African American, men released from incarceration within the past year, women over 30 years old, so we had 48 participants. For Latino and Latina community, men currently employed as day laborers and women under 40 years old. And we also had additional pilot focus groups that we actually began our process with who were HIV positive and negative Latino MSM, as well as HIV positive Latinas and African American men, HIV positive African American men and women. So additional community-based participatory research methods, a mouthful. We're trying to integrate CBPR approaches as avenues for community engagement and dialogue. So these are the two key practices that were part of this. Community forums. So we did 4 community forums in this past year to inform community members about the progress and findings of the study. And during these forums, we also received feedback on the study design and our findings. So we actually just had, so we had 4 forums, and we're planning a 5th forum in the fall of 2012. And what will be different about this, the next forum, is that it's going to be joint African-American communities and Latino. We did a little bit of integration in this last forum on May 5th that was sponsored by La Clinica de la Raza. And within that, we actually had simultaneous translation. So part of what I think is the strength of our project is this real collaborative work that we're doing together and bringing together communities that usually aren't working together or dialoguing with one another. The other part is the Community Advisory Board data interpretation. So 6 participants who are HIV positive and negative, they've been trained in data analysis and interpretation, contributing to the identification of themes and recommendations for pilot projects based on the study's findings. So we have 3 people who are from the Latino community and 3 people who are from the African American community. Some of the results, you can see we have a list of the commonalities, another strength about being able to do this cross community research. So some of the emergent themes, I'm going to mention the last 4 that were brought up in the focus groups, were the potential for confidentiality breaches. This was a concern for members of both focus groups. Communication about HIV and trust in relationships. the low priority of the overall health status. Many times a priority were to get and maintain work and to take care of the families. Comparison of HIV services of Oakland versus San Francisco, which I thought was pretty interesting in both communities. This was brought up about, comparing that San Francisco had more resources. So for example, in the correctional system, the participants saying how there were more, they experienced more resources in San Francisco in terms of like condoms and such than in the East Bay in Oakland. Female specific, and this was for cross communities for both African American and Latino, health concerns are tied to family security. HIV testing is secondary. Also associated with pregnancy, and in both HIV positive African American women and Latinas, often it was either through pregnancy or through already being very ill that they knew that they had HIV/AIDS. As far as for the male specific, for both Latinos and African American men, they didn't seek care until very ill. Both had examples of like, well, unless I'm like really, really like can't barely walk or I've been shot, am I going to go into a hospital or a clinic? And part of that has to do with the social construction of gender, specifically with masculinity. African American specific themes, distrust amongst partners, and they also had existing informal prevention efforts of looking out for one another, of kind of like reporting of like, oh, I saw, you know, the person that you're dating with so-and-so, and so sort of that kind of looking out for one another. The role of church, and those are both positive and negative aspects. For Latino specific, of course, there's language barriers, and that's not only for Spanish, but also with Mayan indigenous languages as well. Also, the availability of clinic hours, which we saw was pertinent with day laborers especially, and concern about immigration status. Okay. So, we're collaborating.
Okay, so here we have divided the potential intervention ideas into behavioral and structural. And down at the bottom, there are a few that bridge both. But in the behavioral side, we saw kind of, you know, innovative ideas like in impromptu street theater, like flash mob for HIV, in laundromats, barbershops, like non-traditional settings, and also group level interventions and dialogues targeting non-traditional HIV target groups. So like day laborers, older women, young Latinas, the kind of like not the usual suspects. All of these interventions were sort of bottom up, using community members to sort of drive the intervention. In structural, the most promising we thought that stood out was the integrated health service delivery and also masking HIV testing and treatment and embedding it into an integrated system. One last thing I want to say before I get cut off is if you're looking at the geo data, the most high-risk neighborhoods, we have a couple of the zip codes up here, but when you layer it with the public-funded HIV testing sites, testing sites weren't really located in the high-risk communities. So one intervention I did is expanding testing availability in those communities, with that expanding mobile testing programs, the extended service hours, and incentives. And our respondents said something to the effect of, you have to come to us because we won't come to you.
Okay, since I'll keep this very short. So in working with one another, with different in the groups, we see how we have to, there's some, we have to take some very new and different approaches to promote HIV testing with the groups, as well as there's cultural behaviors and practices already in place that we can highlight for intervention. We'll mostly be working to reach target groups such as day laborers and young heterosexuals at risk. Part of it that's really key for us in using CBPR is insider participation, and really the importance of CBPR at every level, and which is challenging, but I think it's ultimately it's been very beneficial, and it's required us to be very flexible in our work, which also takes patience with one another. But this flexibility has been very important in trying to really have tangible benefits for the community, so not just doing the model of the parachuting researcher coming into the community. So thank you very much.
And our final speaker is Dr. Susan Keglis from the Center for AIDS Prevention Studies at UCSF, presenting a discussion of an HIV prevention intervention for young MSM of color.
Thank you, Eva. I want to acknowledge Greg Rebchuk on here as well. So today I'm going to be talking more about a program of research rather than one specific study. So the Empowerment Project has been, I've been doing the research on Empowerment Project for a number of years, and it's a community-level intervention that's multi-level as well, and it's designed to address the needs of diverse ethnic and racial groups of young MSM around the issues of HIV prevention. So we did 2 randomized control trials and found the Empowerment Project to effectively reduce rates of sexual risk behavior among young men aged 18 to 29. And it's designed as a multi-level intervention, as I said. As a community-level intervention, a community mobilization approach, it focuses on the entire community of young MSM wherever it's implemented. And so it's being implemented, it's been implemented in over 200 organizations around the country. They're not all implementing it at the moment. And it's used in a range of communities, small towns, large cities, and so forth. And it goes through various social networks. I'm not going to be able to give the full detail of the intervention here. It's being implemented in the Bay Area as well as elsewhere. So these are the core elements of the intervention. There's 6 core elements. Informal outreach has to do with young men talking with and encouraging their friends to be safer. There's a publicity campaign throughout the community. The whole project is run by a core group of young MSM of whatever ethnic racial group it's trying to focus on. And so it's a project that's run by young men for young men. It has formal outreach. We go to venues where young men hang out, as well as create social activities to attract young men, because we know that they won't come to something that says, AIDS here, come talk about HIV. So instead we use social events as a way of bringing men in, and then we infuse the social events with HIV prevention messages. It takes place in a community space that serves as a young gay men's drop-in center. And M groups are one-time small group sessions that give a particularly intense dose about HIV prevention and teaches about how to do informal outreach. So each core element needs to be in place to be effective. They work together synergistically. And it focuses on individual empowerment, community empowerment. The men are taking on these messages and spreading the messages because they're invested in them, and they're taking it to their peers. And it was designed from the start to be adaptable by each community for each community. A number of guiding principles underlie it based on research and formative research we do. These guiding principles guide all aspects of the implementation, and the core elements and the guiding principles focus on individual level issues, cultural issues, interpersonal issues, social issues, and structural issues. So indeed it does get towards some of those upstream factors that we've been talking about. And it's one of the guiding principles is that it's based on the idea of building community, building a community of young men who support each other in lots of different ways. And that has pride in themselves, pride in being gay or bisexual, pride in your own ethnic racial group. No shame. So now what we're doing is we're focusing on implementation research. So we've been doing this research on translating research into practice. You see here a picture of our manual. This is the picture of our manual. We're providing technical assistance. We're really focusing on the system of HIV prevention now. Coordinators, supervisors, executive directors, and funders. And we offer an array of activities now how do I use this again? Oh, yeah. These array of activities that we provide to organizations proactively to help them implement it more effectively. And the Empowerment Project is being implemented in diverse communities and locations. Right now, we're collaborating with 80 community-based organizations around the U.S., 48% of whom solely focus on young MSM of color, of African American or Latino. We've done extensive work to tailor the Empowerment Project to African American young MSM, and that intervention is called United Black Element, or UBI. We have provided guidance specifically about how to adapt it for young Black and Latino MSM based on input from advisory committees, community-based organizations, experts, the literature. We do a lot of community input, get a lot of community input. And we're currently implementing and testing the adaptation of the Empowerment Project for African American young MSM in Dallas, and Houston is serving as the comparison site. And although in the past we used to just focus on safer sex, on reducing sexual risk behavior, well, but I want to make a point, we always focused on both positive and negative. It's just that when the zeitgeist, the current belief was you only focus on negatives, it was kind of hard to keep getting communities to think about focusing on positives. But it's always meant to focus on positives as well. And so right now we're using the empowerment strategies to also increase testing every 6 months. So that's one of the outcomes we're looking at. And we're also in the process of trying to get funding so that we can incorporate into it using the same methods of community mobilization, but around a more assertion around prevention with positives, getting young men into care, maintaining them in care, and adherence, and trying to change the norms about those issues, and trying to change the norms about peers supporting their peers in these areas. Thank you.
Great, thank you. So at this time, we'd like to invite all of our speakers back onto the stage, and we'll have a brief question and answer period.
I'll add that we'll keep the discussion to about 15 minutes because of all of the disruptions, so people could get some lunch.
Got that dose of vitamin D, so now we're all starving. So, stop. Oh. Sorry. Yes, thank you. No, thank you. So in terms of some of our critical questions that we'd like to ask the panel and those of you in the room today, how do we begin to bring the knowledge from international context to domestic community-centered approaches to HIV programming? We heard a lot during the sessions today about some of the processes that are used at the international level, and how can we begin to start to adapt those here in the domestic setting? How do we bring those lessons learned home? How do we get the knowledge that is known in the community disseminated at the highest levels in order to promote rigorous evaluation and document effectiveness? What are the levels, individual, structural, institutional systems level considerations for community and academic partnerships? And what are the best practice approaches to integration and not leaving community-based settings out, considering some of the challenges that we've heard about during this discussion around re-engaging in biomedical approaches? So anyone at the podium? Should I ask initial question? So I guess my first question will go to Ms. Yusuf. In terms of your specific project, given the use of CBPR frameworks for exploring late diagnosis, how can these types of frameworks be used to implement or test interventions? In other words, moving from exploring into action.
Okay. Is this on?
Sure. Got it.
Okay, so I think that, for one, and our data show this also, is that community input is essential. It's not enough to sort of have this top-down framework, because it's not necessarily as effective as when you actually have people from those communities sitting at the table. And so, anything else? Yeah.
And I think a few of the challenges along with that is the different languages that we speak, and so that's something that the process that we've developed in working in collaboration. So for example, we have a covenant of guiding principles where each time at each meeting we actually read it off and to kind of make sure we're on the same page in the way that we're talking to one another. And then sometimes, you know, being able to learn how to be honest with one another, but coming from a very generous place. So I think, I don't know if I'm answering the question, but part of that CBPR, what I said, it really need to emphasize flexibility throughout the process where we've had to make changes. And then also making changes within how we have people involved from the community. So it's not just like, okay, here you are representative, but we've taken the time to actually think about how do we train people so it's beneficial to them, and continuously reevaluating that as well.
Can I ask a question? So thank you for your presentation. It was really interesting. And I'm wondering what it was that you all did to engage the very high-risk populations that you were working with. Because it seems like there's been a lot of conversation over the last 2 days about how to engage those populations and get them in the door and keep them in the door. And given that you all were able to engage them and have them disclose to you some very personal issues, tell us a little bit about how you did that.
So we used a peer, is this on? We used a peer recruitment model. And so we started off with seeds from those communities. And so seeds who are high risk, and incentivized them to bring in members of their peer group. It actually was more challenging than originally thought. Like, we're like, oh, this incentive, they're going to bring in so many people. But it was actually key to find the right seed and the right kind of person for the recruitment. And that works for us, and we've done other peer-based recruiting before. And the social network thing seems to be like a really innovative strategy to getting people in.
And to add a little bit to that, with La Clínica, we also found it very difficult because people we never actually knew how many people were going to show up to the focus group. It was always like, okay, to call and make sure that they were scheduled for a focus group. Well, we learned pretty quickly that doesn't happen. And then being able to identify a few of the women, and interestingly enough, it was more participants who were of an older age that the community trusted more, and they didn't necessarily have to be high risk, but they were knowledgeable and had been working in the community already, and so they were more trustworthy. So that was very eye-opening, as well as the other challenges there were. With word of mouth. I mean, and really part of what I've been with La Clínica for a couple years, and I'm a familiar face, and so that helped to an extent. You know, I wasn't just, coming in as part of the late diagnosis project and say, hey, we need to do these focus groups. I was known to them, so that's part of the benefit of working in partnership with each other. But still, even with that, it took a lot more groundwork than I think we thought it would take.
Just wanted to add one more thing. When we first started the peer recruitment model, we selected our seeds and went out, and again, we thought it was going to bring in an influx of people, but we actually had to do pilot groups in order to get people in, because a lot of the participants weren't familiar with the research process, weren't familiar with focus groups, and so when we came to them with coupons and asked them to come in, they didn't know what we were talking about. And so we did the pilot group so that their peers could explain to them, oh, it's not that bad, it's an hour and a half, and so that actually was able to jumpstart our recruitment. One of the other things that Christina mentioned, like the groundwork, with our recently released populations, we actually had people from those populations help recruit them. So like when I would go into those communities, I wasn't nearly as effective as someone who could identify directly with that experience.
So I have a question for Nick and Maurice and maybe some of the rest of you that have been talking about stigma and discrimination that African American populations are facing, as well as the distrust of the healthcare system. What do you recommend from a kind of CBO clinical partnership perspective as a good strategy to start addressing that, to help bring more people into care and improve the trust with the medical system?
Well, first of all, communication is the key, and relationship building has been one of the most important things that I think builds relationships between the doctors or the clinic that they're serving and the clients. And so it's looking at what are the things that are standing in the way of developing that link, that communication link. And a lot of it is about not believing that they have the power, the clients, to really bring what the issues are to their provider. And so we were looking at navigation as a medium, a place where both the client and the clinic or medical professional could use as a tool to bridge that gap and look at how we might develop a stronger relationship between the patient and their doctors.
Mm-hmm. And I'd like to add to that as well, that I think that it even goes into the churches and families and even the greater communities, because that's where a lot of the stigmas and the barriers are, as far as disclosing, as far as feeling confident with yourself and with the people in your surroundings to get the best care you need. And I think it's really critical about that too.
I also wanted to add, because I think that part of what we also have been hearing, though, is the amount of judgment that comes from providers. And I think, providers are really well-intended. Mm-hmm. And I was a provider for many, many years before I became a researcher, an academic. And folks experience it the moment they walk into a clinic. They get looked at a certain way. If you don't quite look right, you're assumed to be ignorant, and so you are treated in a way of, well, you don't know what is best for you. I know what's best for you. And that comes across whether you intend to do it or not. And so I think until we can address those issues of individual communication between provider and the staff within a clinic and patients to feel that they have that power. It has to come also from training the providers to make them not culturally competent, but cultural humility, which is one of our colleagues talks about, and really truly accept that the patient can be an equal partner.
If I might, I go back. One of the reasons I'm so attached to my model is because it is about mobilizing communities to believe that this health issue is their own. They're not doing it for someone else. They're not doing it because people say so. They're not doing it because the government says so. But it's their own community that's taking this on as an issue. And then the more educated the community is, and that can happen through peers talking with peers, then they'll get it that this is an issue that's important to them. There's so much stigma about going in for treatment, for example, that you might even find out that you're positive, but you really just can't deal with going in. You're so worried. But if you have friends around you who are saying, hey, have you gotten tested in the last 6 months? And let's go together and let's go on together and figure out what to do if we're positive. And so I think having that community that's talking about it, that cares about it. But I think we also have to be aware that, at least in the population I work with, medical stuff isn't the top most important thing. And so, I joke about it, but from the very start of our research, we knew that young men did not want to show up to a place that has HIV/AIDS prevention here. But so you have to do social marketing work. What is important to the population you're working with? What, just like people in for-profit areas pair sexuality with cars or sexuality with brushing your teeth. We've got to think about what are unmet needs that we can meet and then bring HIV prevention aspects, including the whole array, the cascade of care, into that so that they're not just polarized. Health is over here and fun is over here, or interesting things are over here. They have to be married together to meet the needs of people.
Yeah, one of the things that I really appreciate coming out of the panels today was that it isn't the researchers that come up with the questions and kind of bring it to the community, that really all of the knowledge is in the community. Any innovative ideas that researchers have is actually by going to CBOs or to communities and speaking to them and finding out what the problems are. And I think I want to get back to also what Ife said earlier about how the international research is a little bit ahead in terms of really I work in international research, and these conversations have been going on for a long time, and I think we really do need to learn from the type of collaborations that are being established with our international partners and bring that to how we do research with community-based organizations and have communities drive the research agenda. So I really appreciate
one area I want to disagree with you, though, is about MSM research and trans research.
Right.
That there are places that have been doing it, Brazil, Peru, a few other, Thailand, but there's a lot of places where MSM are very much at risk and almost nothing has been done for them. Yeah. And then if you talk about transgenders, it's magnified all that much more.
Hello, I would like to say something. From my perspective, one thing that I would like to see for us to have more community forums for people that are in the community where we could come together with medical providers, CBOs, and address these issues around HIV care and HIV prevention, and just listen at what these clients are telling us. I mean, I think this would be really great to do. And the reason I say that is because years ago we did a health forum in Bayview, Hunters Point, and our main goal was HIV care, but we were able to throw in diabetes, high blood pressure, but then we were able to really get the message across and listen at people from the community and get up and say, what strategies would work for them. So I think that would be a really good thing for us to start thinking about doing.
Thank you for that very much. This question was actually going to be specifically for Dr. Lightfoot, but I think it applies to all of our research and community partners that are here at the table today. And in terms of kind of thinking about these models of community and research partnerships, how can these types of models move us to implementing long-term action and building a sustainable pool of researchers and community-based organizations that are around and developing this knowledge base in order to drive us towards addressing these health disparities. And so, for example, we've talked a lot today at these meetings about this movement of community-based organizations needing to move into more clinical settings in order to be sustainable in this next wave of thinking through about what HIV looks like. How do these types of partnerships begin to diversify and build that knowledge base in order to maintain the connection at the community level?
Sorry. I don't even think I could keep up with that question. I think one of the things that are going to be really, well, what I find to be one of the biggest challenges is just the structural support for these kinds of partnerships. And so I sit on an NIH review group which funds a lot of the research that happens, and having these kinds of partnerships go beyond maybe having a community advisory board, I think it's very challenging. And so I think structurally we need to do some things to make sure that these kinds of opportunities or these kinds of partnerships are sustainable. And in terms of kind of the next generation of faculty who are coming and who will be the ones kind of carrying the torch for this, I think also it requires a lot of the training that early career folks get, include CBPR type principles. We are hounded and pounded about academic process and the scientific method. And I think we need to equally be hounded and pounded about how we even generate some of the questions that we think are going to make an impact. And we have the luxury of, or at least I have the luxury of working in a more applied type of setting, a public health setting, and doing research. And I think that the more that we ask the questions around, not only this is an interesting research question, but so what? You know, the so what questions, what kind of difference will this make? I think also it's going to be important as we think about moving forward with new research ideas and new directions for what we want to be doing.
So, you know, I would argue that we've become a little too dependent on these things being separate activities rather than integrated activities. And I think that, you know, I came from a community health model. I worked in community health centers for many years. And we didn't separate these activities by grants. And I mean, I know resources are really important, but there was something very different when it was just part of what you do as an organization in order to sustain it. And I think that some of that is, again, going back to the leadership of the agencies and the institutions and asking, how does everything you do have an evaluation component, have a way to get community input from clients, from science, to join together, and how do we then implement activities that respond to those? Because I think, again, for the sustainability part, unless it's sort of part of our daily activity that we do, it's going to continue to get cut. I mean, I sort of feel like it's where education is going. It's like if we keep, you know, before we know it, we're all going to be homeschooling all of our children, and maybe that's not a bad thing, but, you know, I think there's just something about our, again, how we integrate versus separate some of these activities.
And just to add, I think training the next generation of researchers from the community will be a critical component. So just because we're getting to the end of our time, I just want to see if any of our panelists have some burning questions for each other. Oh, someone had a question here? Anyone?
I was just interested in what the panel thought about home testing and if that becomes available. It's got some great advantages in that if people are disenfranchised from medical systems, we might get more testing done. On the other hand, we are really challenged with linking people into care when they find out they're positive. So it seems that just throwing testing out there isn't going to be enough. So I'm just wondering what you all, I'd love to just hear your thoughts about how you would harness home testing, if and how you would harness home testing to help with the work that you do.
Well, I'll jump in real fast just to say home testing again, because we did have it before, and we had struggles with it then. So I think having options is always good, so I think having more options. I think it, you know, again, who will purchase it and who will use it is a huge question still in my mind. I think folks, again, who, it may help folks who suspect and would like to know, but not necessarily still tell anybody. But I don't know that it would, it's hard, I just don't know that it's going to change testing patterns per se.
I have some concerns about it, but I think one important issue is that there's still segments of the community that don't get it, that AIDS meds are really good these days, that they really save lives. I find myself working in the community I'm working with in Dallas, young black gay men, that they still are very surprised at the idea that finding out that you're HIV positive isn't a death sentence anymore. You know, they hear negative things about meds, they have a bias against meds, but I think we need to do, and it's a double-edged sword. You don't want to tell people it's so easy that people then lose their motivation to avoid HIV. On the other hand, we're going to be promoting PrEP, which is, you know, take meds even if you're not positive. But I think we need to get more of the message out about how there's a reason to follow up into treatment, and that is that you will live. I think that message, we just assume living around here that everyone gets it, but really people don't necessarily get it because they don't read the same media, they're not part of the same communities and so forth. So I think that's a really important message to get out.
Does anyone else want to add?
I just want to add one piece, and that was something that I heard yesterday in one of the presentations about telemedicine. And, you know, I think a lot of people that would get involved in home testing and look at the results, especially if they're positive, might have an issue with still getting the treatment. And looking at telemedicine as a tool to link to the idea of home testing might be an option that would actually support this idea.
Great. Are there any other last comments? Questions?
Hi. So my question is for Christina and Aminatu. I was really interested in how you trained your CAB in the research methods and the data analysis. I'm just curious about what the follow-up looked like in that and how that was disseminated into the rest of the community.
So actually that's just very recently begun, so I can't really give you that perspective yet, but we had a training session that Amina was present at. Maybe you want to talk about it a bit more. Yeah.
Okay, so we did a training session with the members of the CAB who were actually handpicked by the partner agencies. And the training session was conducted by Meredith Minkler and other folks who are trained in CBPR. They were kind of given insights as to how to look at the data and the different ways in which to view it in order to pull out the themes. And so like Christina said, it's a work in progress. It's still currently being developed all the way. It's in its beginning stages, but it does seem like a promising way to look at community-driven solutions.
And I would just add that we do plan to disseminate the information to community once we've completed looking at the results.
So we have a plan in our calendar timeline. They will be disseminating information to African American and Latino communities and looking at how they can function as liaisons too. So for another example of how we have to be flexible is that we noticed, well, for the Latino ones, it was very difficult for me to find bilingual Latinos because being part of the CAB, they're going to have to be able to read materials in English and work together. So when working with Ife on our last conference call, we talked about, okay, so we have, there are a bunch of like monolingual Latinas who have just great ideas. And so we're like, okay, well maybe with our, the CAB members, we can also do additional groups to still get ideas and still get feedback on the ideas that the CAB members are having as well. So keeping that kind of process open as well, you know.
Hi, I appreciate all these presentations because I work at the state and sometimes you get this bird's eye view and you attach numbers to these populations. So it's really, really humbling to see the people who are actually working with the late testers and the young black men and so forth. So I appreciate these presentations a lot. I think my statement or question, it's kind of both, is I hear a lot of talk about the research academic partnerships with community levels, but we're leaving out kind of some critical, the county health department and the state level, or, to a lesser degree, and in specific looking at surveillance data to inform sort of what we're doing. And I know I know a lot of you are doing it. I know, Cynthia, you mentioned a lot in your presentation, this sort of like, that's where you're going to start. I guess I have a question about how, if anybody wants to elaborate on how you do collaborate with the county and how you use surveillance data to inform your programs, but also to reiterate that this, we have, at the state, we got funded for a geocoding project that really can help at the census tract level, and all the counties actually, you can have that data back, So I really want to reiterate that we have that. As some of you, I think, will look at the zip code level, but we can even have the census tract level. So, use us. We're working at trying to get that, the community viral load and the geocoding project kind of tightened up, and then you can use that for your own purposes. So I just kind of reiterate that, and then kind of have the question about how you use the data to inform you.
So maybe if I can just interject here, because we're about 45 minutes after lunch, and I know people are probably getting a little bit hungry. We do have, another discussion this afternoon, and we have scheduled plenty of time for that. So I think maybe we can continue some of these discussions, but I think the point you made was really excellent. So we basically brought the first presentation of the conference back to the last panel, and I think that's, excellent cross-bridging from day one to day two. So if the moderators don't mind that we pick this up after lunch, but before we go for lunch, now those of you who are here have self-selected yourselves for a very important task. So lunch is easy, it's just a box, so you can just pick up a box and have your lunch, so it's not too difficult. But what you need to do during that period of time is take one of those sheets of paper on your tables and write down 1 to 3. So it has to be at least 1, and it should not be more than 3 key things that you are taking out of this conference that you think need to be addressed. So it can be behavioral, it can be clinical research, it can be structural, but it should involve it should involve, different groups that are represented here working together. So please write those down. And you can put your name on the sheet of paper, or if you don't want to, you don't have to. But we really need every one of you to go through this exercise, and please leave them. Probably the best thing is to just leave them on this first table down here. So we will be collecting them, and when Susan and others come back for the panel, they will actually read through them, and hopefully out of that we can then create also the next steps in terms of what we want to have come out of this conference. So 1 box of lunch, that's easy, 1 or 2 or 3 questions on a piece of paper. Your name may be on it or not, as you wish. And I think what we will do, since we're kind of late, I do want to give everybody some time to actually get lunch, think of the questions, maybe have a few more chats. So let's come back here at 20 of 2. So basically in 25 minutes. So in 25 minutes, we'll gather back here for the final discussion. And so for those of you who still had questions for this panel, bring those back for the last discussion. And you guys did an excellent job of setting the stage and having the panel moderated in a way that everybody participated in a very integrative way. So congratulations. I love the way you did it.
Thank you to the panelists for excellent